Everybody looks lovely. Very impressive team. I'm proud to be part of it.
I'm happy to. It's a lovely team.
While I'm on this screen, I can't see the chat. Connie, you ought to see it in case someone talks to you.
I'm not sure that the chat.
Oh,
I
yes.
can see the chat.
Yeah, no,
I
it's
can
come
see
up. I've brought it up now.
But
Can you
I,
see-
Yeah.
I don't know if the chat is specific to this room. I guess so.
Yeah. We'll soon find out. Oh.
Rio, can you put in the chat the name of the room that it's dialogue? Oh, it is. I see it. Okay. Thank you.
My pleasure.
Good on.
Okay, I think we're ready to begin. Can you hear me okay? Just give me a thumbs up. Okay, so good morning, everyone. My name is Dr. Connie Soban-Sensor. I'm a professor of nursing at Rutgers University, and I represent the League of Women Voters of the United States at the United Nations. I'm very happy to be the moderator of this group this morning. The dialogue is women's safety and access to healthcare. And I would like to introduce our panel of distinguished speakers, and then we'll proceed with the dialogues and the conversation. So I'm briefly going to introduce our speakers, and then when they start their part of the dialogue, they will tell you a little bit more about themselves. So we have with us this morning Dr. Claire Fotheringham. She's the head of the medical unit in Sydney, Médecins Sans Frontières, Australia. And for those of you that are not familiar with the French version, I'm told that it's Doctors Without Borders. We have, if you just want to give us a little wave, Claire. Thank you. Okay. And it's very late in Australia, after midnight at this point. So we're grateful to have people with us in New York time early. And we have Professor Gabrielle Casper. She's the head of the Department of Obstetrics and Gynecology, School of Medicine in Sydney, the University of Notre Dame, Australia. And she is also the president of the International Health Awareness Network. Okay, and our our next speaker is Miss Mary Muia. She is a representative of Soroptimist International, and she's with us today from Nairobi, Kenya. Okay. And so I'd like to begin with Claire. And Claire has a PowerPoint that she's going to present. So I'm going to let her share her screen.
Hi, okay.
And I'd like you, Claire, to tell us a little bit more about yourself. And then the question that we're posed for you is, how has conflict influenced women's access to healthcare? So you have the floor.
Thanks very much for that. So I'm a doctor and obstetrician gynecologist by training. I started working for Médecins Sans Frontières in 2011, working in some of our projects globally, and then moved on to being Women's Health Advisor and now head of the medical unit. So the topic I'm going to be looking at today is how conflict influences women's access to healthcare. So, there we are. So women and children face some of the most significant indirect impacts and bear the greatest healthcare costs from conflict, even though they're usually or mostly not participants in the conflict. So I'm going to talk of some of the ways in which women's health is impacted by conflict, and speaking primarily from my own experiences. There's a whole Lancet series on the effects of armed conflict on women and children. So if interested to know more or look in more detail, then I encourage you to read that. So I think one thing that's really important to remember is that women as healthcare consumers factor risks into their calculations about when and if they'll seek medical care. And obviously those decisions are impacted by the social and cultural circumstances in which they live. But it's important to remember that they have that agency in choosing to seek healthcare, and that they make those decisions in a rational way about whether it's appropriate to seek healthcare or not. So that might mean that they delay seeking medical care for emergencies, for example, waiting until daylight to reduce risk. But sometimes those decisions, those calculations can be fatal. So I remember when I was working in Afghanistan, we always knew when dawn came that we would get the worst cases, because often people would not travel at night. It was too dangerous. And I remember one case in particular, a woman who came in and died almost as soon as she came in from a bleeding complication that would have been very easily treatable if we'd seen her sooner. But she and her family had made, what in the end was actually a very valid assessment that the risk to them from trying to move during the nighttime was too great to bring her, and so waited until daybreak to bring her. I think also when it comes to less emergency situations, more routine situations, in conflict settings in particular, where there is risk to women, they just won't seek care. So routine appointments like antenatal care, postnatal care, family planning, abortion care, they won't come to, despite the fact that that might reduce their risk of complications and emergency situations, but they judge the risks as being greater than the benefits from care. So here's the mum life going on here. So transportation also exposes women to risk. So there's attacks, roadside bombings, landmines, risk of kidnap and sexual violence. And there's also risk in movement from medical staff. So that means that it's hard for medical staff to meet women where they are. So issues with trying to have mobile clinics or home visits, which might ameliorate the issues around transportation, can be difficult. Sorry. Oh, darling. Mwah. Yeah, almost done. Now, obviously, my area, I mostly look at reproductive health needs. It's important to remember other healthcare needs in conflict, but also particularly an issue for women. So, for example, in Yemen, where I was in a trauma centre, we often saw many of the patients that we saw were with injuries from were women or children, often from going to collect water or looking after animals. Okay. And equally, displacement can cause specific issues. Often with keeping medication, things like family planning, and also vulnerabilities such as sexual violence during the time of displacement. Just a warning before I go to the next slide, that it is a little bit graphic, but I think it's important to recognize the issues that women sometimes face in seeking healthcare. So on the very extreme end of it, women can be attacked for just being in a healthcare facility. So as an example, a healthcare facility in Dashibashi Hospital, which is run by Médecins sans Frontières, was attacked in May 2020. Gunmen killed teen mothers-to-be, and also a MSF midwife, Méaghan, and others present at the hospital, including children present for vaccination. This has a chilling effect on healthcare, not only at that facility, but also a wider impact. Attacks like this not only remove access for care for women at the hospital, they mean that Afghan women are less likely to seek medical care when complications occur during labour and delivery in the future. It's not an isolated incident. It perhaps had more international coverage because of the involvement of an international NGO, but smaller attacks go unreported internationally, but have local impacts in terms of women deciding to seek healthcare. So that's just a very brief overview of the issues that we see. Obviously, we're working hard to look at solutions as well for these things, but I look forward also to the discussions here today for ideas about how to tackle these issues. And as I said before, please forgive the mum life. Normally my baby's in bed at this time, but sometimes we have to make do, so thank you for being patient.
Hey, thank you. That was wonderful and informative. And next we're going to hear from Gabrielle, and she also has a PowerPoint to share along with what she would like to talk to you about. And at first, she's going to tell us a little bit more about herself, and then she'll proceed with answering this question, which is, how has COVID-19 influenced women's access to healthcare? And Gabrielle, you have the floor.
Thank you very much, Connie, for moderating the session. Can you hear me?
Yes, we can.
I'd also like to thank the UN Department of Global Communication Civil Society Unit for inviting me to take part in the event. My name is Gabrielle Casper, and I'm a Sydney gynecologist with a special interest in women's health and human rights, including violence against women. I'm president of the International Health Awareness Network and past president of the Medical Women's International Association and International Women Doctors Association. And if I can see if I do, these are the students who assisted me to prepare this presentation. It was always nice to have help. COVID-19 is reversing decades of progress in women's health, especially for the world's poorest and the most vulnerable women. COVID-19 has globally impacted women's health due to many factors, including lack of access to healthcare services, lockdowns and travel restrictions. Many health facilities are closed or are providing only limited services, reduced quality of care due to telehealth. Many women and girls are choosing to skip important medical checkups for fear of contracting the virus. There are also global supply chain disruptions that may cause shortages of medication, including contraceptive supplies, as well as unemployment, poverty, poor diet, and nutrition. Disruptions brought about by the pandemic has caused the rise of women's morbidity and mortality from all health issues, including infections, heart disease, diabetes, and cancers. So here in the next 5 minutes, I'll just shed a light on a few of these problems. I'd like to, can you hear me still?
Yes, we can.
Good. I'd like to start with sexual and reproductive health. As COVID-19 continues to spread, there's been a decline in access for women and girls to sexual and reproductive health services, family planning, and maternal health. The United Nations Population Fund and Evan Health conducted an analysis of 115 low and middle income countries in January 2021. And due to COVID pandemic, it's projected that 12 million women could not access modern contraceptives, resulting in an estimated 1.4 million unintended pregnancies during 2020. Another important issue is access to maternal health services during COVID-19. Most causes of maternal morbidity and mortality can be prevented by giving prompt, suitable treatment to the women by qualified health practitioners. Maternal health services, which include antenatal care, delivery care, and postnatal care, can play a crucial role in preventing maternal health problems. In a recent coronavirus pandemic, this has had a disastrous effect on healthcare delivery of people of all ages on a global scale, but pregnant women face particular challenges. Due to this pandemic, women worldwide are facing more barriers to accessing maternal health care, including restrictions, transport challenges, and anxiety over the possibility of being exposed to coronavirus. The United Nations Population Fund ran a model to assess the probable effects of COVID on sexual and reproductive health services, including 3 indicators, namely births assisted by skilled healthcare providers, institutional delivery, and access to contraception. The analysis was focused on countries in the Asia-Pacific region. The results showed that even in the best case scenario, the use of these services would decrease by 1/5 of the present value, while in the worst case scenario, utilization would decrease by 1/2. This would subsequently lead to between 17 and 43% rise in maternal mortality. Despite the efforts to boost maternal health in both developed and developing countries, many states around the world have reported a significant rise of pregnancies ending in stillbirths, where babies die in the womb. This increase in stillbirth has been shown across many countries. Basically, in St. George University Hospital in London, there was a 4-fold increase in stillbirth, while in Nepal, it was 50%. So what's being done? UNFPA have continued to invest in women's health across the Western Central Africa region through emergency SNRH and emergency obstetric and newborn care. In Uganda, UNFPA have created an e-shop which delivers subsidized contraceptives, HIV tests, pregnancy tests and childbirth kits to the doorsteps of the women during lockdown. It is evident through this example that we must continue to find creative solutions to address resource allocation in order to improve women's health outcomes. Women's psychological health. Pandemics are an important risk factor for anxiety and mood disorders across gender and cultural cohorts. Specific factors that cause mental distress include quarantine or isolation periods and social distancing, which causes fear, social isolation, and frustration. Increased exposure to pandemic content on social media consistently increases psychological distress. COVID-19 and postnatal depression. Internationally, rates of postnatal depression have risen dramatically in response to COVID-19. As you can see from these figures, it is an increase that is international. Long-term psychological outcomes are yet to be understood, but based on existing knowledge, negative implications may be substantial and requires longitudinal research to assess the development and health of those impacted. COVID-19 worsens precarity for refugee women. This is also a global crisis. At least 79.5 million people worldwide have been found to flee their homes. Among them, 26 million refugees based on 2019 data. COVID-19 affected immigration on a global scale. Refugee intake during COVID is the lowest it has been in 2 decades. The risk of COVID-19 is further amplified for refugee women living in camps and settlements where physical distancing is near impossible and healthcare services are already overstretched. I'm sure you all know about violence. It's now been recognized by media and governments around the world that living conditions and restrictions, combined with soaring unemployment rates, financial instability, and the global increase in stress and anxiety has made the perfect storm for a rise in domestic violence, a health crisis described by the UN as the COVID-19 shadow pandemic. I just want to mention a special case of young girls and COVID. UNESCO estimates 111 million girls living in low-income settings are currently out of school because of COVID-19. And where the families, due to unemployment and also there are obviously families that are suffering unemployment and poverty. And due to this, there is now an increase in selling young girls as child brides and daughters pimped out as prostitutes to feed a family. As if conflict and climate instability were not bad enough, now COVID-19 poses great threats to the health of women and girls. I will finish with the words of our WHO Director General. There is no doubt that the pandemic has set back global efforts to improve the health and well-being of women and children, but that should only serve to strengthen our resolve. Our joint action under the Every Woman, Every Child movement is more important than ever. We now must renew our commitment to a healthier, safer, fairer, and more sustainable world for women, children, and future generations. So with our lovely session we're having today, the United Nations are happy to host with all of these fabulous NGOs. I have 3 words to finish on: advocate, educate, and collaborate. Thank you.
Thank you, Gabrielle. And we're certainly going to hear more when our dialogue opens up about advocacy, education, and collaboration. And so I'm hoping that all of you are starting to come up with some solutions to the problems that are presented, or some questions for our speakers. And I'd now like to introduce Ms. Mary Muia. She's coming to us this morning from Nairobi, Kenya, and she is representative of Soroptimist International. She's going to tell us a little bit more about herself. And then she's going to focus on the question of, Mary, how has COVID-19 influenced access to healthcare for adolescent girls and young women living in informal settlements in Nairobi, Kenya? Mary, the floor is yours.
Thank you very much, our moderator, Professor Connie, and thank you very much to everyone and the previous speakers for the good connection of our topic. I come from Nairobi, Kenya, like you say, and I am a public health professional, and I work in the social arena. I work in prevention. And so my focus is in social work to work with groups and families to prevent disease. In this particular topic, my focus will be on adolescent girls and young women and how COVID has influenced their access to healthcare. I really, in my work, I do a lot to have adolescent girls and young women prevent teenage pregnancies, child marriages, economic resilience, and even traditional harmful practices. So in this presentation, I will want to highlight a case that I'm working with the girls that are in extreme poverty of the slums of Nairobi. Thank you very much. I think I will want to share a screen to start the conversation. Just a minute, I'm getting it, I think. I got it, I think. I got it now. I'm not able to share. Can I think I can just
Try the green
share
button, the green button at the bottom of
Yes.
the screen,
Yes, yes.
and then you should be able to click on your PowerPoint.
Yes, it's up. It had just shared earlier. Oh. Sorry.
Okay, it's here. We have it.
Do we have it?
We just did a minute ago. It was the screen with your bio on it. Is that the introduction to your PowerPoint?
It's all right. I think I'm not sure why it is loading now. I saw the issue now. Right, I think I will just pick it from here, from where I am, so that we don't waste time. I think my computer is trying to reload, and I don't need to wait for it.
Or Mary, you could send to me Ryo-Sekiguchi the file, and I can maybe instead share with you if you don't mind, or whichever you prefer.
Okay.
Okay, I'm gonna send you my email address soon. Okay, thank you.
Yes. Sometimes the technology.
A couple of minutes of discussion and then come back and then have the talk.
Yes, I think that would be good because it had loaded earlier very well. All right. I want to look into the factors that affect healthcare access for adolescent girls and young women in informal settlements, the case of Nairobi. Nairobi, just like many other cities, has got a big portion of it that has got slums or informal settlements, and 60% of Nairobi population is living in informal settlement. Nairobi city has a population of 400 million people, and so we are talking of 60% of that are families and population that lives in extreme poverty or in informal settlements. The informal settlements conditions on healthcare already are disadvantaged, and we are aware that access for healthcare for families that are in these extreme poor conditions is quite dear. Sanitation, for example, and access to clean water for drinking is unheard of, and if they access the water, normally it is not adequate. They have to buy water, they have to arrange for ways of waste disposal, because sewages and modes of sanitation are quite dear in these conditions. More often than not, you shall find children, most of them young girls, playing around with very dirty water, and if it is not it's not a wonder that most of them, children, girls, will be reporting to healthcare facilities with hygiene-related diseases such as diarrhea and the like. For the better part of the girls that I've worked with, and since COVID-19, 2020 was a very specific year because adolescent girls and young women have got special health needs. We know that girls and young women in this particular age require special attention because they are transitioning from childhood through puberty to young adults. And their sexual reproductive health needs are quite intense at this particular period. We know that adolescent girls and young women are at a high rate of risky behavior, such as unprotected sexual intercourse, and they expose themselves to diseases such as HIV. We know that in high country burden, high HIV countries, Kenya is one of them, and many other countries in Africa. So new HIV infections register in girls aged 15 to 29 to 24 compared to their male counterparts. And so these girls accessing adequate information, proper dialogue with their counterparts on how to avoid risks is quite necessary. We have seen, because of COVID-19, many girls that were in school where they access this information and services to be able to protect themselves came into a stop because children and girls had to stay home because of the lockdown and the closure of institutions. What this led into was that we have seen a surge of violence that also was directed to girls, and particularly sexual violence. Thank you, Dr. Claire, for Gabrielle, for highlighting that 900 million adolescent girls and young women were affected by COVID-19. A proportion of those are the ones that I'm talking about, and that we have seen that pregnancy, teenage pregnancy, has really gone up in 2020. Through to the same, the girls cannot now get into their healthcare, to get healthcare in terms of antenatal care, and so they will end up with unattended for needs during their antenatal period. This means then that delivery and their access to safe care during childbirth is questionable. We have also seen that many families have had a lot of stressful environments because of COVID-19, and many young girls and young women have bared the brunt of this violence, either as victims of physical violence, and many of them have actually been taken advantage of by men, like Dr. Gabrielle highlighted. They are forced into marriages as a way of making the families earn a living. This then is the question that we are I'm looking into. When we talk about strength and resilience for gender equality, how do we strengthen access of care for adolescent girls and young women for them to be able to overcome these challenges? We do also have shelter and daycare centers where these girls can be housed in the slums. But because of COVID-19, again, the shelters were closed down, and the girls and the adolescent, the girls and the young women ended up without proper rescue homes where they can be able to go and shelter as they think of their next move now that they have found themselves pregnant. I will not finish before I highlight the economic impact of COVID-19 to families, including young women, that most of women employment in the slums, 70% of them are in informal economy. And so when we went into COVID-19 closure and lockdowns, all small businesses were lost and they lost income to that effect. I do want to say that mental health and psychosocial support services for most adolescent girls and young women remain as a big option for us to support them, and if they will be able to get their themselves back in accessing healthcare. We must prioritize mental health and support networks that is still not sufficient at the moment, because if a young person wants counseling services, they will either have to look it up in a directory, and maybe most of them don't have mobile phones. And so they will rely on the adult who is next door or who is together with them in the same household. COVID-19 has also increased the cases of gender-based violence, and particularly to this vulnerable group. And we are saying that they no longer have support, either at family level or in school or in institutions where it was easier earlier on before we experienced this pandemic. If their families are not accessing economic empowerment or economic opportunities for daily survival, the girls then are turned into brides, and they are sold off, or they are taken advantage of through commercial sex or through child prostitution that will now support their families in essence. This is a big blow, and we are saying that as we approach the decade of women and girls resilience, we have got to look into access of healthcare for girls and young women that are living in the slums, because they form a special population that if we do not support them at this point in time, then they end up with their adult lives that have been destroyed, and that their healthcare access is really not what they would have dreamed of. My call, I think, will be to join Dr. Gabrielle in collaboration and creating awareness and working with all stakeholders to ensure that adolescent girls and young women access the right information on sexual reproductive health. Our healthcare facilities are friendly, and that they support girls and young women to have confidence to seek services from them, and be able to share the correct information amongst their peers using safe spaces and also rescue shelters where possible. Connie, I would want to end there by thanking you and the rest of the panel for the patience that you have had during this presentation. Thank you so much, and my apologies about my PowerPoint that could not load. It's restarting, and I think we had to use the time as it is. Back to you, Connie.
Okay. Thank you so much for that presentation, and the dialogue was wonderful, even without the PowerPoint presentation. You did a wonderful job of explaining the current state of what's going on in your area of the world, in Nairobi and Kenya, and the settlements. So at this point, I would like to open the dialogue to the participants in the room. I would like to remind you all that the session is being recorded. If you can turn on your cameras, we would appreciate seeing your video presence. And we have with us also Meaghan Boyle. She's a rapporteur. She represents the civil society unit, and she's of the global Department of Global Communications, and she's an intern there. And so she's going to be taking notes. And when we conclude our session, about 10:15, we're going to reconvene to the main session. And each of the rapporteurs from the 5 sessions will present summaries of the sessions. So you'll be able to hear not only a summary of what happened here, but what happened in the other 4 sessions as well. So I'd like to, at this point, you've heard some of the root causes about women's insecurity related to COVID and related to conflict, and barriers to accessing healthcare from our impressive panel of experts, from Professor Gabrielle, from Dr. Claire, from Miss Mary. And I want to say that you too may be experts. So as the conversation continues, we hope to share solutions to the problems. This is really, we all know the problems exist and we've acknowledged this, but let's talk about solutions. What's working for you in your NGOs, the work that you do, or in your part of the world? So along with questions, please focus your remarks on successful examples of interventions that your groups have used. And when called upon, please introduce yourself and your location and your NGO affiliation. And please limit your remarks to a couple of minutes so that everyone can participate. So I think that if your video is on and you can raise your hand, that would be the best way to be called upon. So let's give it a try. The floor is open. You can ask questions of our panelists or share your solutions.
May I ask, Mary, what do you need most? Do you need us to support you with advocacy so that your government helps you more? Or is it just a matter of money? What would you need if you could wave a magic wand to help you with your situation?
Wow, Dr. Gabrielle, that is a nice one. It's a combination of all, because it is a right of every citizen to access healthcare, and governments and the county or city governments are obliged to provide healthcare for their population, and so even including the ones that are the informal settlement. So yes, partnering and influencing healthcare facilities from the public sector to be able to be friendly and available to support women and girls that are in these extreme conditions is a way to go. Community projects like the one that I do also help them to form groups, and particularly peer education groups, where they come together in mentorship sessions, and the girls are able to influence one another through receiving the correct information with their mentors, so that they can recognize what it feels like to want to go to the clinic. Many girls never want to go for antenatal care until there's a problem. But if they are in a project that is talking about this, then they are urged and they will be able to go to clinic and get the services of antenatal care before delivery. So it's a combination of all that.
Yes. Marnita?
Hi, can you hear me?
Yes, we can.
Yes, Mary, thank you for your presentation. If you could just describe the healthcare system in Nairobi, like whether it's public, private, and how people access care. And if you have a wish list, what's on the top of your wish list to make sure that healthcare is increased and made better for all?
Nairobi is both public and private. And the public facilities, we do have the National Referral Hospital, and we do have units of few other hospitals that are within the city. But majority of the population are expected to cater for their own health by either paying an insurance fee or having a national hospital insurance fund that will make them access services. Now, because of poverty, women and girls cannot be able to pay these premiums so that they can be on the cover, that is the National Health Insurance Fund. And so first things first, I think it is to get them educated, to get the girls into school, to get the girls into economic empowering opportunities. Then they can begin to think about healthcare as a basic need that they need to attend to themselves. So that is one. If it would be a wish, it's that even in the informal settlements, government should have public healthcare support, whether through a hospital or clinics, or even mobile, a way of making sure that these services are accessible to these families that are in severe conditions. And it is not their wish, they want to work, but they cannot have employment. They do informal businesses, but they are not earning enough. So it's, yeah, so education for me is girls, so that then they can unlock and they can change the tide about poverty in their families.
Thank you so much.
Katherine?
Hi, I'm Katherine Brundage. I'm one of Dr. Sensor's nursing students at Rutgers University in New Jersey. First of all, I would like to thank all of the speakers for their time in creating such wonderful and thoughtful presentations. My question is directed at Gabrielle. In the time of COVID-19, regarding the rise of domestic violence and women being trapped in these situations where it might not necessarily be safe for them to get out of their situation due to lockdowns, what can we do? What are any potential solutions?
Katherine, very good question. And if I had the answers, I'd probably win some Nobel Peace Prize or something. But I guess it's multifactorial. I guess what I like doing is I like looking at other countries and seeing what they're doing and sharing what people are finding is successful. And I'm learning a little bit more about social media at present. And apparently some countries have got a few warning things what a woman can do. And apparently with TikTok, there's quite a phrase where if you film yourself on TikTok and do particular 3 hand signals, that means I'm at risk now and I need the police. And then you quickly get a sign up saying where you are. And then your partner may not hear you doing these hand signals and may not see the sign. So TikTok have got some things running at present. Certainly some places have got somewhere where you ring the emergency number, whether it's for us 000 or you, I think it's 911 or 199, and you ring the number and you say, I need to order a pizza and I want pineapple, whatever the sentence is. And that's the sentence that's the in thing to let people know there's an emergency that you need access. So I think there's quite a lot of people these days that are trying to use, it doesn't prevent it, but at least if someone tries to ring the police or ring for help and their husband hears, it can be a very risky situation. So they're just trying to work out what is an emergency way of doing it. I know in Australia at present, there is quite a large amount of emergency accommodation that the government has set up, which means that people can be quickly moved out of a house into emergency accommodation. But the big question about how do you prevent violence against women, I know everyone has their own opinion, but to me, I believe men aren't the problem, men are the solution. And if men want to act and they want to train their sons how to behave with women, and if men want to stand up and call out inappropriate behavior in the workplace or in discussions, men could solve this for us. And so while I've been going to the CSW for 25 years now, and it seems to be the same discussions keep coming up. I think when I turn to the CSW and I see 7,000 men in the room, I believe that's when we're going to start seeing an improvement in the issues. But I'd love to hear everyone else's opinion on what you believe would help to truly prevent violence against women and try to keep them safe across the globe.
I sat in on an interesting presentation that really focused on prevention. It involved basically looking at technological solutions to provide systems of alert. You had mentioned the international hand signal, which is, I think, gaining momentum as a way of alerting, people when they're in danger and their perpetrators are standing right by them, and it's hard for women to get out of that situation. So I think that's gaining traction. These particular solutions were part of a hackathon, and I thought that was an incredibly innovative way to kind of look at things differently instead of dealing with the consequences, trying to look at it from a preventative perspective. And we do have a lot of technology out there, and to harness that technology, to use it to prevent domestic violence before it happens, I think is a path that we probably need to strongly embrace. Which I didn't think of in those terms before I sat through that presentation. So I think that's one path that we can start looking at. I think having men as allies, I think you're right, Gabrielle, to see thousands of men in the room with women and trying to gain an understanding of what our issues are and how they impact those issues and how they can affect change. I think that is incredibly important. So I think looking at men as allies in this, because we're all in this together, I think is a way to promote some type of communication, some type of change. So.
Mhm.
Thank you. Another thing is, when you speak with women, about 35% of them will tell you the first time they experienced violence in their relationship was when they became pregnant. Mm-hmm. And it's a shame someone couldn't get hold of that couple at that first event and say, she's pregnant, you've flipped a funny switch that makes you want to bash her. We need to stop this now and not let this continue. And I think we need to really strengthen the resources around the obstetric side of that first time when a woman experiences violence or when the man does the violence.
Mm-hmm. Claire, you brought up some scenarios from being in situations where there's conflict. I wonder if you could share with us a little bit about any protective measures that are out there when you're in a conflict situation, because it seems like that's also a very vulnerable place.
Yeah, so I guess obviously working for an international NGO, a lot of time is spent trying to negotiate humanitarian space, whether it's with kind of formal armed participants or what is often more tricky and more complicated is prolonged and protracted conflicts in fragile states that don't meet the level of being a war, although war zones themselves are very complicated. Often it's really, there's always healthcare present, often in formal sectors if the formal sectors have broken down. So it's also often about trying to link in with those. And while it's probably not revolutionary for many people, for a medical organization that's quite doctor and to a lesser extent nurse-centric, one of the responses that we've had with COVID-19 has really been trying to push more aspects of self-care and trying to help women to deliver their own healthcare with assistance. So through using telehealth, also through, dropping medications with instructions for how to use it, for example, rather than asking women to come to see us. And that's had some success and some failures. I think I was reflecting on the discussion about intimate partner violence, and certainly we've certainly found that with telehealth, that is a struggle. It's not so much the struggle of having someone there that can listen in. We've kind of developed code words that could be said to make that clear, to try and protect women. But often it's about control of access to devices. So control of access to phones, control of access to many things, to ability to leave, ability to seek care. So I think that's something we've really struggled with how to overcome. And I think that's also, it's an element of privilege in Australia. Almost everyone that I know has a smartphone, but that's not the case for a lot of the projects a lot of places where we're working.
Well, I think we're really out of time in terms of questions and remarks, but I wanted to go back to our speakers and express our gratitude for them. They're joining us and sharing their stories with us this morning. And just amongst our speakers, if you have any closing remarks or some commentary that you would like to add in about a minute or less per person, so that we are on time. We're due to head back in about 4 minutes to the main session and wrap up. But thank you all for being with us and being part of this community this morning. Mary, Gabrielle, Claire, whatever closing remarks you'd like to add. Go ahead, Mary.
Thank you. I think I want to thank everyone for that animated talk. And my words will be that adolescent girls and young women will not be bedridden and will not require the kind of healthcare their parents require. We have to rethink what it is that we are offering. We need to give them correct information about sexuality, contraception, and safe sex. And we also need to protect them from violence and give them safety nets that they can be economically empowered for them not to fall prey to the wrong hands. That's my closing remark. So I call upon everyone to support all projects that are working to protect girls and young women.
Thank you.
I'd just like to say that 20 years ago, I formed what I call the Australian Women's Coalition, and I have 19 national women's NGOs in my coalition, including Zonta, Soroptimist, Jewish, Muslim, Baha'i, and those 19 organizations gives us a very powerful voice when I go to government and say, my Baha'i lady friends have been to you last week and you didn't help them. Please tell me what you're going to do so I can let my couple of million members know whether you are actually going to help us. So my suggestion is find all your women's NGOs in your country, form a group, and then go to your government and argue as a very powerful, large group.
Thank you.
I feel inadequate after those two very, very rousing talks. I guess my closing remarks would be really, I think, it's so exciting to be part of a forum and to listen to people and see the ideas that they're bringing forward. Médecins Sans Frontières has a very medical focus, but we know that there are so many things that impact on women and girls' access to healthcare, and it's really exciting to see everything going on in that space. I don't think it's for an international NGO often to be telling people locally this is how you should do things, but to see people taking it on themselves is very exciting, and hopefully we can see progress for the future.
Thank you. So I hope that the presentation with the solutions that have just been presented have energized you, that there are certainly strategies that should make us feel strong and empowered as women, strategies that we can use in conflict and in pandemic situations for protection and accessibility to healthcare. And we can't do it as women without men on our side. So for the men that are in the group, we need you as much as we need women to advocate, to educate, and to collaborate. So thank you to everyone. And in just a minute, we'll be returning to the main session. So I hope that you can stay with us. And it looks like we have 2 minutes if there's anybody else. I see some things in the chat. Someone says that we need to have a advocacy toolkit. And the education of mothers to educate their sons and their daughters.
One of my women doctors suggested that the parents go to prison for a son who does inappropriate action towards women, which I thought was an interesting way of rearing children. I don't know any country that does it, but it did interest me that the parents may take a greater interest in rearing sons that do not perform violence against women.
Well, it just shows you the powerful role that everyone has, you know, and in this group especially, we have, you know, a very global perspective from different parts of the world, and yet we see that the problems are not all that different, regardless of where we are. So whether you're in a developing country or a developed country, we all have work to do. And one humanity, one planet, and we're all in it together. So thank you again to everyone for joining us. And we're going to move back to the main session now.